Hello, everyone. It is now 11 o'clock, and we are going to get started. As another reminder, all participants are muted. If you are having any technical difficulties, please disconnect from the webinar and reconnect, and that should fix the issues. If you have any questions throughout the lecture, please feel free to use the Q&A feature on Zoom, and we will answer them at the end of the lecture. Thank you for joining us today for the AAN Virtual Resident Education Lecture Series. Today's topic is Movement Disorders Emergencies. I am pleased to introduce our speakers for today. First, we have Dr. Zain Guduru. He is an Associate Professor of Neurology for the Movement Disorders section at University of Kentucky. He is the Adult Residency Program Director. He completed his medical school in India in neurology residency from Allegheny General Hospital, Pittsburgh. He completed his Movement Disorders Fellowship at Augusta University and was trained by Dr. Kapli Sethi. His predominant interests in movement disorders include botulinum toxin injections for dystonia, Parkinson's disease research, and Huntington's disease. Joining him today is Dr. Ashwini Kinney, a PGY4 neurology resident at the University of Kentucky and chief resident for the year 2022-23. She previously completed medical school in India and neuro-ophthalmology fellowship at Houston Methodist Hospital. Thank you for both of you for joining us today. Dr. Guduru and Dr. Kinney, I turn this over to you.
All right. Thank you so much for the introduction, and thanks to AAN for this opportunity to present. So as Ben was telling, I'm joined by Dr. Kinney, who is our about to graduate resident from University of Kentucky. So I'm going to share the screen now. So today we are going to present movement disorders emergencies. We do not have any disclosures. This presentation is going to be a case-based approach where we are going to just show you the videos of various movement disorders which were acute in presentation, and it will be followed by discussion and management. So let's start with our first case, Dr. Kinney.
Okay. So our first patient for the day, this what we are seeing here in the video, he's a middle-aged man. He does not have any significant past medical history. Basically, he presented with this abnormal posture, and this was after he received a particular medication. Video. So what we noticed here is there was a gaze deviation to the up and right. His head is also turned to the right, and there is some difficulty in breathing for the patient. He denied any association with pain. There was no change in mental status. And as I said earlier, all this started after he received a medication, and we'll talk about that in a little bit.
All right. So with that introductory video, I want you all to understand, when you're seeing a patient with movement disorders, the first thing which you got to do is describe the abnormal movement that you're seeing. Description is the first step. Once you describe the movement, think about what type of movement disorder it is, and then take the next step of where the movement is present. Is it present in the head and neck region? Is it the whole body? That's how you got to describe. That will help you with your differential diagnosis, will help you with localization and management. In this video, which you have seen a man with a movement disorder called dystonia, where the definition of dystonia is there's intermittent or sustained muscle contraction causing abnormal posture or tremulous movement, or both. Usually it is worsened by active movement, or it can be initiated by some active movement. And in our patient, we had two, we have seen dystonia affecting the neck, which is cervical dystonia, and also there was persistent gaze deviation, which is called oculogyric crisis. Persistent gaze deviation without any change in mental status. It's one of your differential, it's called oculogyric crisis, which is nothing but dystonia. This dystonia can affect any area of the body. Depending on the area of the body, they have termed various, they have coined various terms. When it affects the orbicularis oculi, it's called blepharospasm. It can cause trismus, jaw opening dystonia. In our patient, we have seen cervical dystonia. And there was also some laryngeal spasm too. That's what was the description of difficulty with breathing. It can affect the trunk and extremities too. When a dystonia starts suddenly or acutely, always take a step back and ask for what medications was the patient exposed to. Drug-induced movement disorder, one of the common example is acute dystonia. The exposure to anti-dopaminergic medications. It can be antipsychotic medications or it can be anti-nausea medication like metoclopramide. They can cause these acute dystonic movements. Usually about 50% of the patients experience their first signs of dystonia within 48 hours of drug intake, and most patients it's within 5 days of drug initiation. Couple of risk factors for this is younger men. Younger men are at higher chance of developing these acute dystonic reaction. Now, question is, why is this so important that that we are discussing this? When you happen to identify a person with acute dystonia, you have to look out for, or you have to predict that these complications might happen. The most dangerous one is respiratory stridor or acute respiratory compromise. It can also cause muscle breakdown, causing myoglobinuria, rhabdomyolysis, and eventually leading to renal failure. It can cause jaw dislocation, dysarthria, and dysphagia. Now, from this slide, I think it's quite obvious that identification of acute dystonia is important, and treating them urgently or emergently is important to prevent these complications. And the way you treat them is using anticholinergic medications or benzodiazepines. Your first line of choice is anticholinergic medications. You can choose benztropine or trihexyphenidyl, and it's better to choose intravascular, IV or intramuscular route because you want faster treatment here. IV is the route of choice, and usually once you give the medication, the benefit you can see within 20-30 minutes. Even after 30 minutes, you do not see the benefit, it's okay to go ahead and give the second dose of the same medication. You can consider alternative of antihistaminergic medications like diphenhydramine, again, IV form. If you do not get benefit with these anticholinergic medications, then you can take the next step of choosing benzodiazepines like diazepam or lorazepam, clonazepam, again, IV route. These are your treatment of choices, okay? Now let's say you have given one dose, there was no improvement. Again, as I said, give the second or third dose of anticholinergic medication, if necessary in half-hour intervals. Very important point to remember. Once the symptoms have improved, just don't stop medications, just don't stop this treatment. You need to continue PO maintenance at least for 7 days with gradual dose reduction to prevent recurrence of that dystonia. Okay, please remember this. All right, here you go with the same patient after the treatment.
So this is our patient. He received 1 dose of benzodiazepine injection, and you will see that there's marked improvement from our earlier, what we had seen of his dystonic posturing. So the medication he had received initially, it was metoclopramide, after which he had developed the acute dystonic reaction. And this was his response after 1 dose of benzodiazepine. See this marked improvement. And he's back to his baseline.
Okay, so improved, but again, remember, you need to continue that medication in PO form at least for 7 days to prevent recurrence. The take-home message from this case is, do not miss this diagnosis of acute dystonia. It happens in the setting of anti-dopaminergic exposure, most likely within 2 days of exposure to that medication. Young men are at high risk. Okay, let's move on to the next case.
So our next patient, she's a young 26-year-old female presenting with these severe abnormal movements, which you will see in a bit. So she has a prior diagnosis of dystonia at age of 7. She had a brother who was similarly affected. When she was 20 years old, she had bilateral globus pallidus interna Medtronic DBS placed, and her symptoms were under good control after the DBS placement. And when she was 26, the impulse pulse generator, it's basically the battery of the Medtronic DBS, it was changed to Boston Scientific, and there was a change in the parameter. So they went from continuous voltage to continuous current stimulation. And within a few hours of this change, this was what was seen, what we'll see here on the video. Her movements were significantly worse. So we are seeing here, there's abnormal posture involving her head, neck, trunk, even her extremities are involved. There is blepharospasm. And you'll hear that sound. Yes, so that's from laryngospasm. There's retrocollis, there's forward bending or camptocornea, and there's dystonia of extremities. So this is generalized dystonia with hyperkinetic movements, which we just saw in this video.
Right. Okay. All right. So before we talk about what this is, I want you to, notice one thing. Dr. Kinney has described the movement first, and then while describing, also described where exactly the abnormal movements are present. That's the way you got to describe the movement and then come to a conclusion of what movement disorder it is, then take the next step. So in the young woman, you have seen that there's abnormal movement, there's sustained muscle contraction. Over that, there is increased muscle contraction, various body regions. There is a pattern to it. Even though you see twisted movements, there is a pattern to that abnormal movement. The way the trunk bends forward, that's all dystonia. So whenever you have the trunk involvement and at least two contiguous body segments involvement, you describe that as generalized dystonia. The kid had generalized dystonia and the dystonia was persistent, constantly happening to the point that she is not able to eat, she is not able to drink. When you see this kind of pattern, you need to think about the word status dystonicus or dystonic storm. So what this means is there is increasingly frequent or continuous severe episodes of generalized dystonia, which necessitates urgent hospital admission, right? This is one of the rare complications of dystonia. You can see the graph on the right side of the slide. Whenever there is frequent or continuous severe episodes of this dystonia associated with metabolic disturbances, you have fever, dehydration, electrolyte abnormalities, creatinine kinase is elevated, the muscle is breaking down. In addition to that, if you also have any respiratory or cardiovascular compromise, when you see this kind of pattern, you need to think about this term, think about this condition, which is status dystonicus. The reason to think about this is you need to act very fast in this case. You need to admit the patient to ICU. I'll talk about management in a bit. Usually you'll see many of these patients are aged between 5 and 16, almost 60% of the cases. There is many a times there is a clear precipitant. It might be some febrile illness, some infection, medication adjustment, or there is unplanned interruption to the DBS, which has happened in our case too. The way you manage this patient is you need to admit the patient to ICU. You need to think about precipitants. It might be, as I said, it might be some febrile illness or infection. Treat with antibiotics. Any precipitant factors are there, stop them. And if the problem is with DBS interruption, you can restart the DBS or whatever has happened with DBS, you need to address that. Then bring in the supportive care. As I said, when there is severe dystonic movements which are happening continuously, it leads to electrolyte imbalance, renal failure. You need to address all those things. IV hydration, antipyretic medications, monitoring the electrolytes and creatinine kinase, renal function tests, and if needed, you probably need to intubate, if there is a laryngospasm pretty significant. Then you need to calibrate on sedation. You can give chloral hydrate, you can give IV clonidine, midazolam, or general anesthetics. And also you need to start treatment for dystonia specific medications. You already heard about dystonia-specific medications. You can try anticholinergic medications or benzodiazepines. Again, you need enteral route for this. Sometimes the levodopa can help in levodopa-responsive dystonias. And even then, if there is no benefit, or if there is subnormal benefit, you probably need to go into neurosurgical intervention, urgent deep brain stimulation surgery, or repositioning the lead. So this is how you manage acutely the status dystonicus. If you do not diagnose or treat early, the mortality is very high. It's almost 10%, and you see mostly in men with tonic phenotype. Okay, and here you go with the same patient, the video pre and post surgery.
So in the initial part, you see here the patient is admitted to the hospital. There's a feeding tube that is placed because of the dysphagia. She was taken to the OR to replace the device back to her original Medtronic IPG model and the original stimulation parameters. So we'll see that initial part and see how she improves after being coming out of the OR. So this is before the surgery.
Can you look here? Can you tell me what's your last name? Turn your head to the right. Turn your head to the right. Your head pulls to the left. Okay. All right. So tell me, how are you doing since the surgery? Better. Okay. What's better? Close your eyes. Tell me the months backwards from December.
December, November, September, October, July, June.
What kind of sports do you like? Games? What's that?
So you can see here she's back to her previous baseline. She was discharged home after the procedure. This was during her follow-up.
Okay, you can go.
All right.
So it was a great case of, plus unfortunate case of status dystonicus, but trigger precipitant factor was identified, and then it was duly addressed. That then the patient immediately went back to her baseline. Again, you can see that post-surgical video, the dystonia completely does not resolve, but at least she went back to her baseline, how she was prior to the initial surgery, right? So point to remember is status dystonicus definition and how to address that, when to take the patient to the ICU and when to consider urgent surgical modalities like DBS. This is one of the indication for urgent or emergent deep brain stimulation, status dystonicus. Okay. All right, let's move on to the next case. And while the video plays, I want you to think about how to describe the movement and where exactly the movement is present.
So this is a 39-year-old female. She with no other significant past medical history. She had some viral illness with cough, chills, muscle soreness. And about a week later after that, she developed vomiting, blurred vision, and unsteady gait, and presented to the emergency department with this abnormal eye movements. So what we were seeing here was very high frequency, multi-directional dancing eye movements. And this is Opsoclonus. And what is not seen here in the video is she also had myoclonus in her extremities. She underwent some extensive testing. She had imaging, MRI of her brain, which was normal. A lot of series of serological and immunological testing. viral titers, ANA, lupus, complements, rheumatoid factor, immunoelectrophoresis, all of them were negative except for elevated IgG and IgM for HSV. So this was thought to be secondary to HSV infection. She was treated with methylprednisolone, and then, which she got it IV initially, followed by oral prednisolone. And then this was tapered off after a month. She also received clonazepam orally for a month, and there was complete resolution of Opsoclonus a month after treatment.
Okay. Again, first thing first, the description of the movement. There was involuntary, chaotic, multi-directional saccades without any intersaccadic interval. So there was sudden jerky movements in multiple directions, but there was no gap or interval between each saccadic movement. When you see that it is multi-directional, the term for that is opsoclonus. It is often associated with sudden jerky movements anywhere else in the body. It's called myoclonus. That's why this condition is called opsoclonus myoclonus syndrome, right? You might have heard this from your medical school, in children, 40 to 50% of the children, when the opsoclonus myoclonus syndrome you see, they have underlying neuroblastoma, which is the reason for that, and you address that neuroblastoma or you treat that. Also, to remember, only 2 to 3% of the cases with neuroblastoma, they have opsoclonus myoclonus. So it doesn't happen always. In adult neurology world, about 20% of opsoclonus myoclonus syndrome patients have underlying paraneoplastic disease. Many of them can have small cell lung cancer, breast cancer, ovarian tumors, GI lymphoma, non-Hodgkin's lymphoma, or melanoma. Couple of antibodies for you to remember as neurology residents. One is anti-RI antibody, which is associated with breast cancer. It can cause this syndrome. And the second one is anti-glycine receptor antibody associated with lung cancer. It can cause this. More common than this is post-infectious or autoimmune etiology. And that's what you have seen in that patient where it was thought to be post-herpes simplex virus induced autoimmune condition presenting as opsoclonus myoclonus syndrome. So it can be para-infectious, post-infectious, but it's thought to be autoimmune in nature. It can result from post-viral, post-bacterial, or post-immunization too. We had one patient last year with similar presentation. You want to talk a little bit about that case?
Yeah, we had a young female. She was postpartum and had COVID infection. She was admitted here for abnormal movement. So similar to what we had seen here, she had opsoclonus, she had myoclonus in her extremities. In that case, it was thought to be post-COVID infection. And there are a few case reports which have been published on that too. So the mechanism is thought to be similar. It's immune-mediated reaction, post-infectious immune-mediated reaction. And she was treated similarly. She got 1 month of clonazepam, and there was complete resolution of the opsoclonus myoclonus, and she was back to her baseline.
Right. So the take-home message from this is the definition of opsoclonus, and it happens in adult world. It happens often in post-infectious autoimmune settings or paraneoplastic conditions. Accordingly, your workup should be, and the treatment depends on the underlying condition and also addressing the autoimmune pathology with immunosuppressants. Okay. So far, you have seen 2 cases where there were abnormal movements of eyes. The first video you have seen today was oculogyric crisis, which is nothing but dystonia affecting the ocular muscles. And this video which you have seen is opsoclonus. Okay. Please remember all these terminology. Let's move on to the next video.
So this patient, he's a 61-year-old male, has vasculopathic risk factors. He presented to us with acute onset right upper extremity weakness and numbness. He was coming in as a stroke alert to our emergency room, but by the time he presented, his weakness had resolved. Instead, he started having abnormal movements in his right upper extremity. And this was not associated with any change in mental status. and the typical stroke alert workup was done. His glucose level was normal. Initial scan, CT head was normal. He was admitted, he got an EEG. This was also normal, and the movements were captured on the EEG. And we'll see the movements here.
Yes, I started having this thing on the right arm, and it just when I got the Lakesville Hospital, I had blood pressure. So they said it's got high, so this is where I've been treated.
So we are seeing here the abnormal posture in his right hand.
Backwards from December.
The fingers show splaying. And what we are trying to do here is trying to distract him, and we see that these movements are non-distractible. It's jerky and tremulous. It's present also at rest, posture, and on action. And this persisted even in his sleep, and this was not associated with change in mental status. As we see here, he's communicating back appropriately.
Right. So very important point. Again, you describe the movement, you see that there is abnormal posture, which you can call as dystonia, but it also comes with these jerky movements, which are tremulous. You think about possible seizure, and that's why the EEG was done, which was reported to be normal, right? Whenever you have unilateral movement disorders, always do the brain scan, look for contralateral structural lesions. It's a take-home message. Whenever you have unilateral movement disorder, you need to look for, do the brain scan to look for contralateral structural lesions. That's how the brain scan was done here. This MRI scan, you see the DWI ADC sequences at various levels. You can see here, there's subcortical and cortical DWI positive lesions, which are scattered, multiple small scattered areas in cortical and subcortical regions in the left, predominant in the left frontal region. That's what we have seen in this patient. So this brings us to the topic of stroke-induced movement disorders or cerebrovascular accident-induced movement disorders. You can have movement disorders after a stroke even in an acute onset fashion too. The most common movement disorder which results after a stroke is chorea, and the most common or frequent location of stroke is lentiform nucleus or thalamus. But also notice that the lesion can be anywhere else in the brain. It can be in subthalamus, posterior limb of internal capsule, or frontal lobe, parietal lobe too. The second most common movement disorder after stroke is dystonia. Again, the frequent location is lentiform nucleus, especially the putamen. There are various movement disorders which can result after the stroke, and that's what this table shows. Usually the latency between acute stroke and onset of abnormal movements varies from movement to movement. Chorea usually develops acutely. It can start on the same day. Parkinsonism is very late to develop. It can take weeks to months to develop Parkinsonism after a stroke, right? So you might think basal ganglia is always the location of stroke or pathology with these movement disorders. Not always. You can see here, there are many other areas, including the cortical, subcortical areas too, which lesions can cause movement problems. So a couple of take-home message points are: the same movement disorder can be caused by lesions in the different areas of the brain. It can be lentiform nucleus and thalamus, the different areas of the brain where the movement disorder can be pretty much the same. Or one cerebrovascular accident can cause multiple movement disorders too. Okay. The most common type of stroke which leads to abnormal movements is actually small vessel disease with small deep infarcts. So this is the patient after the treatment. So we thought about, we'll show the video and then we'll talk about what we thought.
So he was in the hospital, he was given a single dose of benzodiazepine, and he showed some mild improvement. And then he was started on valproic acid. He received a loading dose, and then he was started on a maintenance of 500 milligrams 2 times a day. And his movements improved, what we'll see here, and he remained asymptomatic at 4 days and at the last 6-month follow-up.
October, September, or October, September, no, shoot, I don't know. In July,
You see his movements, his posture, everything has improved.
All right. So we thought about, there was abnormal posture dystonia and also these sudden jerky movements, which you think about seizure. There was no change in mental status. We thought about epilepsia partialis continua, and that's the reason for doing EEG. The epilepsia partialis continua, the EEG can be normal, may not capture on that EEG, but with the clinical diagnosis, we have treated him with valproic acid, benzo initially, and then followed by valproic acid. He has improved significantly. So look at this next video, which is somewhat similar in terms of presentation, but will tell you a very important difference, how to differentiate the stroke-induced movement disorders versus that condition.
So he's a 55-year-old male. He has recent onset diagnosis of diabetes mellitus type 2. And he presented to us with 2 weeks of abnormal movements, mostly noticed all on the right side of his body. So you can play the video.
I had high sugar.
So he's saying his blood sugar was very high. It was
How
375.
high was it?
375 when I had first check.
So what we are seeing here is writhing movements in his fingers of the right hand. There are dance-like or coriform movements on his, he'll take the mask off in a bit. Yeah. So it's in his face, arm, as well as in his leg on the right side.
Put it down. Put it down.
And in between, we see that these movements are also
what do
proximal
you
and
do?
some larger movements. And this is more suggestive of hemibalism on top of the hemichoria that we are seeing. You can notice the movements on his face also.
All right. Put your hands up like that, both. All right, come back, sir.
Okay. All right. So you just heard me already telling, whenever you have unilateral movement disorder, always look at the brain scan. So that's what was done in this case. There was a CT scan too, which I'm not showing, but this is the MRI scan of this person. You can see on T1 sequence, there is hyperintensity of the head of the caudate and especially the putamen, right? And this is on contralateral side. And you do not see any DWA positive lesions, right? So what you saw on the video was hemichoria, hemibolism affecting the right side of the body. On the scan, you're seeing hyperintensity on T1 on brain MRI, right? This patient has very high blood glucose without anion gap. This was a case of hyperosmolar non-ketotic hyperglycemia causing hemichoria hemibolism syndrome, HCHB, hemichoria hemibolism syndrome. This is a result of hyperglycemia-induced pathology. We do not know exactly why this lesion develops and why this movement happens in hyperglycemia, but one of the theory proposed theory says there is petechial hemorrhage affecting the caudate and putamen, especially. That's what caused this pathology. That's what caused this movement problem, right? Now, when you see this condition, when you see this presentation without any associated weakness or numbness, you have to check for blood glucose always. I'm sure you all know whenever you suspect stroke too, you always have to check blood glucose. When you see this hyperosmolar non-ketotic hyperglycemia picture, think about this condition, because the treatment is pretty much the same. You treat the underlying blood glucose, that glycemic control itself is sufficient in 90% of the times that the movement will resolve within a couple of days. If the glycemic control is not helping you with the movement from symptomatic standpoint, you can consider treatments like risperidone or antipsychotic medications like risperidone on a short term. Now, what happened in this patient was we did the same thing. Blood glucose was controlled. It did not help the movement. For symptomatic control, we tried risperidone. Comes back to the clinic in 4 weeks, and the abnormal movements were still present, a little bit better, but still present. And then risperidone was changed to deutetrabenazine, which is off-label use in this context, but it has helped his symptoms. Okay, so point to remember 2 points. One is unilateral movement disorder, always do the brain scan. The second one is don't miss this treatable condition, hemichorea, hemibolism syndrome. Let's move on to the next case here.
So this was a patient who was seen here in our hospital. So this is a 3-month-old infant, born full term, and was admitted recently to the hospital, was inpatient for a prolonged period for about a month from acute hypoxic respiratory failure from RSV and Neisseria meningitis pneumonia, which was treated appropriately with a course of antibiotic and steroid, and then was discharged about 10 days prior to the subsequent admission. The mom started to notice some abnormal full body movements closer to the prior discharge, but went home, but started noticing these movements were getting worse. And just 2 days prior to the subsequent admission, they were significantly worse. And the mom's worry was, my baby does not stop moving. And we'll see what's going on here. So we see these dance-like movements again flowing from proximal to distal direction. You can see it affecting all the extremities here. So the baby underwent quite extensive testing on admission. They did an EEG. The movements were captured. It was normal. MRI of the head with and without contrast was normal. Got basic serum labs, which was negative. Got a lumbar puncture with CSF analysis. The initial studies, including the counts, chemistry, infectious workup, everything was negative. The answer came back sometime later when the NMDA titer in CSF was positive.
Okay, I think it captured all the movements you got to see. So the clue in this case, when you have acute onset movement problem, which is associated with some change in mental status, anything, think about this. Think about NMDA encephalitis in your differential diagnosis. The clue in this case was patient had some CNS infection, and followed by that, there were these movements. There were these choreiform movements. That's when you get this kind of history, think about NMDA. It's probably the viral infection has exposed the underlying antigen, causing this antigen antibody and antibody development, causing this autoimmune disease. When you think about NMDA encephalitis, one very important point for you all to remember, there is age-dependent presentation. When you see adults, usually the way they manifest is there is neuropsychiatric disturbance and behavioral problems initially. But when the NMDA presents in children, Usually it starts with epilepsy or movement disorders like chorea, which are more prominent. You can see on the slide, the top picture here, almost every patient will have movement disorder presentation in NMDA encephalitis. And most of them also have psychiatric manifestations and cognitive symptoms. When you come here, MRI is abnormal MRI. It's seen only in 25%. That means only 1/4 of the individuals you can see abnormal MRI, and CSF abnormality only in half of the patients. So the point which I'm trying to make is clinical diagnosis is more important than your, all the tests which you do. You can do lumbar puncture, it might be normal. You can do MRI, it can be normal, but clinical diagnosis is important. This needs to be diagnosed and treated appropriately. The way the presentation happens is usually there's combination of movement disorders, psychiatric symptoms, cognitive symptoms. There can be epilepsy, dysautonomia too, and they can vary in terms of when exactly these symptoms are presenting. When it comes to movement disorder, any type of movement disorder can manifest too. The common ones are dystonia, stereotypies, and chorea. These are pretty common ones, but it can cause any type of movement disorder. And finally, look at this colorful picture here. All that this is telling is one person can have combination of movement disorders. This person can have combination of chorea and dystonia and chorea, right? One person can have combination of movement disorders. When you have combination of movement disorders, think about drug-induced movement disorders, think about infections, think about these autoimmune conditions, right? One take-home message from this is NMDA encephalitis can cause age-dependent presentation. In adults, usually it's neuropsychiatric manifestation initially. In children, most often it's epilepsy and movement disorders initially, right? You might have read about delta brush with on EEG. It's not that common, but when you see it, it is quite specific for this NMDA encephalitis. MRI, the most common lesion which you can see is lesion in the hippocampus, hyperintensity of hippocampus. You can see that. Okay. Let's move on to the next one. So before that, so the management includes treating with immunosuppressive medications. The first line immunosuppression is IV methylprednisolone or IVIG or plasma exchange, and eventually you might need to consider second line therapies like rituximab or cyclophosphamide. Almost 50% of the patients you might have to think about second line treatment too, and continuing that treatment too. But think about what is triggering it, what is underlying. Is there any underlying ovarian teratoma? If you happen to see that, you need to surgically resect it. You need to work with the surgeon. So for that, you will have to do transvaginal ultrasound too to detect these kind of tumors, which are often associated with NMDA encephalitis. Okay, this is the same patient.
So here we see our patient after. So in the hospital, the child got 3 days of IV steroids, methylprednisolone, and there was no prolonged continued treatment afterwards. And there was complete resolution of the movements on follow-up, what we will see here. Movement subsided with just the acute treatment in hospital and did not require any prolonged treatment afterwards.
Okay, all right. So we brought this NMDA encephalitis case specifically here included in emergencies because this is again a treatable condition. You need to identify and treat them soon enough, and they can present acutely to the emergency room with neuropsychiatric disturbance or acute movement disorders. And these are the patients which are associated often with change in mental status that you will need to manage in ICU setting. Okay, let's move on to the next one. This is the last case and the topic we are going to discuss.
Okay. So this is an 18-year-old girl. She's from South America, otherwise healthy, no other past medical history. She presented with this 6 weeks of mostly gait impairment, inability to walk, and recurrent falls. And now she's not even able to stand without support. And we can see this video. There is no history of exposure to antidopaminergics. So what we are seeing here, she's unable to stand up by herself. She needs at least a one-person support with the walker. She has this tendency to lean backward and a tendency to fall like a log without the support. You can see here she has some difficulty lifting her feet off the ground. They appear almost stuck. She has shuffling gait. She has freezing until she's prompted to move forward. Notice some tremors. They're a little subtle, but you can appreciate the tremors seen here at rest. You can see the reduced eye blinking, reduced facial expressions. And they are giving her a task here, and she's finding it very difficult to initiate or complete the task. It's from the bradykinesia. All this is giving us a picture of parkinsonism. So this is the glabellar tap sign. You can see the persistence, the eye blink.
Okay. All right. So the first and foremost, before I describe the scan, what you saw in the video is parkinsonism. So by definition, you need to have bradykinesia along with resting tremor or rigidity or both. That's what that patient had. In addition to that, had gait, significant stance and gait instability, that she was just not able to even stand up. All this has happened within just 4 to 6 weeks. When you have this acute or subacute presentation of Parkinsonism, first thing to inquire is, was any exposure to antidopaminergics? Antidopaminergics, because the drug-induced Parkinsonism often manifests subacutely within a month of exposure to antidopaminergic medications. And that's why in the history, when Dr. Kinney was mentioning, there was no history of antidopaminergic exposure in this patient. When you see that kind of scenario, the brain scan is a must in these cases, because you want to look at structural lesions affecting the basal ganglia, causing this kind of manifestation. And that's why MRI was done, and you can see significant symmetrical hyperintensity affecting globally all the basal ganglia regions, which is associated with edema 2, And this patient underwent extensive workup and was found to be immunocompetent, but also was diagnosed with cryptococcal infection and was treated with amphotericin B and flucytosine, and with which she had significant improvement. So when you see any acute Parkinsonism picture, think about infections, viral infections, especially HIV or PML. Encephalitis lethargica is one example. Back in 1920s, when there were many of these viral infection cases causing Parkinsonism. Drug-induced, as I just mentioned, they usually manifest subacutely. Toxins like carbon monoxide, they can cause acute manifestation of Parkinsonism. And metabolic osmotic demyelination syndrome, especially extrapontine pathology, when you see in this osmotic demyelination syndrome, can cause Parkinsonism. So that's why to look for all these, you need MRI scans to look at structural lesions, right? So this patient underwent the treatment, and this is a follow-up scan, brain scan, 4 weeks after the treatment, and you can see the significant improvement in the brain lesions, and clinically too, patient has improved significantly. Okay, so the take-home message from this is any acute Parkinsonism, provided if there is no antidopaminergic exposure, brain scan is a must, and treat that underlying problem. You will see the improvement. Okay, the time is 50 minutes into this. I'm ready to take questions in the next 10 minutes. So thank you so much for joining. All right, I have 2 questions. We are going to go over those, and please post your questions too. So let's see. Okay. The first one is for stroke-induced. One second. So for stroke-induced movement disorders, what's the prognosis? Do they require medication for the rest of the life for these movements? Okay, so good question. For stroke-induced movement disorders, it depends on what kind of movement you're seeing. The more common one and the one which presents acutely is stroke-induced chorea. For these are almost 90 to 95% of the times they are self-limited. Within 4 to 6 weeks, these movements resolve on their own. But if the symptom is bothering the patient, yes, you would treat with symptomatic medication like antidopaminergic medication. I would suggest using atypical antipsychotic medications rather than typical antipsychotic medications. Very important to remember, when you happen to give the patient a antidopaminergic medication to improve the symptom, you need to follow up the patient within 4 to 6 weeks. You don't want that patient to continue taking that medication forever, because you don't want that patient to develop some other drug-induced movement disorders like drug-induced Parkinsonism or tardive dyskinesia. Bring the patient back to your clinic. Hopefully the movements are resolved by then. If they did not resolve, then take the next step of thinking about dopamine depleting medications like deutetrabenazine or valbenazine. So to answer your question, stroke-induced chorea, many a times it resolves on its own. If it's bothering them, then you can consider treatment. When it comes to stroke-induced Parkinsonism, which develops over months of the stroke, many a times it does not improve on its own. Sometimes the medications like levodopa might help some, but the prognosis is not that good in terms of improvement of symptoms in that context. So it depends on what movement disorder you're seeing after the stroke. All right, the next question was about valproic acid. I think you're talking about a case who had stroke-induced movement disorder. We have shown the video, and on day 4 of valproic acid, the symptoms have improved. I think our diagnosis there was epilepsia partialis continua resulting from that stroke from the cortical lesion in the left frontal region. That's why the benzodiazepine initially and followed by that valproic acid has helped those movements, and the epilepsia partialis continua have resolved. And for that patient, the movement was persistent even in the sleep too. So the next question is, do all movement disorders resolve during sleep? Many movement disorders resolve during sleep. The classic example for this is you see a person with Parkinson's disease who has resting tremor. Almost all the times when they go to sleep, the resting tremor, that movement problem resolves in sleep, right? But not all movement disorders. You see a person with palatal myoclonus that persists in the sleep. You see you can have a person with hemifacial spasm that can persist even in the sleep. Tics can persist. So there are certain movement disorders which can persist in sleep, but they're not common. Many do resolve in the sleep. Yeah. So valproate stroke. So valproate. This was regarding the stroke patient with dystonic tremor and frontal infarct. That's correct. That was the patient I was describing. Okay. The next question is about which which dose of risperidone do you reach before considering deutetrabenazine in hyperglycemia, hemibolism, hemichoria syndrome? The question is about the patient we have shown with hemichoria, hemibolism syndrome. So risperidone, I usually start at 1 milligram twice a day, right? So that is 2 milligrams per day. Then I advise them to call in a week or two. You can go up on the dose to 2 milligrams twice a day. I don't go up too much on that dose because this is also the age group or the population who are at a higher risk of developing drug-induced Parkinsonism or tardive dyskinesia, right? So once I reach up to 2 milligrams twice a day, if there's no benefit, then I bring them back and I consider changing to deutetrabenazine. Deutetrabenazine is a newer generation dopamine depleting agent, which is unlikely to cause drug-induced Parkinsonism or tardive dyskinesia. That's why we consider changing that to deutetrabenazine. Okay. All right. Any other questions? So let's see if I'm missing any questions here. Okay, I don't see any other questions here. All right. So for patients on, there's a question. So for patients on antipsychotic medication for a long time who develop symptoms of Parkinsonism, aside from shifting to medications with lower propensity to cause Parkinsonism, is there benefit to giving carbidopa-levodopa? Right. So it's a good question. Sometimes you end up with this problem. So one point to remember is treating one drug-induced problem. The solution is not treating with an additional medication. The solution is to stop it or change it to something which doesn't cause that problem. Now, you are treating a person developing drug-induced Parkinsonism. Usually, they're aged above 40. And they manifest in a subacute fashion. And many a times it's because of antipsychotic medications, which are antidopaminergics. Now, typical antipsychotics, which are old generation antipsychotics, they have higher propensity to cause it. Higher dose of antipsychotics have higher propensity to cause it. The solution there is, why is the patient on antipsychotic medication? Who is the psychiatrist or the primary care doctor managing that? You'll have to pick up the phone and talk to that provider, address that mood disorder too parallelly while you're addressing the Parkinsonism. Yes, it involves a lot of work, but it is this management collaborating with other providers is very important in this context. To answer your question, when you have drug-induced Parkinsonism, your postsynaptic dopaminergic receptors are already occupied with these antidopaminergics. Now, giving over that, if you give carbidopa-levodopa, it's unlikely to benefit. Maybe there are some receptors which are not yet occupied. You might get a little bit of benefit, but also remember that you give dopamine to a person who is being treated with antipsychotics. Probably that patient has bipolar disorder or psychosis. The dopamine can exacerbate that mood problem, that psychiatric symptom too. So there are multiple moving pieces here. I would not suggest adding carbidopa-levodopa to a person with drug-induced Parkinson's.
Wonderful. Thank you so much, Dr. Gaduru, and thank you so much, Dr. Kinney, for being here today. Thank you for everyone who asked questions. The next virtual resident education lecture series will be on August 3rd with Dr. Roy Stroud, and you will see this recording if you need to revisit on YouTube. Thank you, everyone. Have a great day.